full block even with 1 ml of local anesthetic. So this is a proof of concept study showing that a tiny volume of local anesthetic, because ultrasound can improve accuracy, you can achieve the block. But remember the block, the low dose of local anesthetic determines the onset, the success, and duration. So this study looks at the success rate and the onset, but not the duration. Looking at interscaling block, again, a very small dose, 1 ml, 4 ml of local anesthetic can achieve analgesia when the local anesthetic is targeted at specific nerve root, C5, 6 nerve root, C7 nerve roots. For peripheral nerve, like median nerve and ulnar nerve, 2 ml is all you need to achieve a block with mepivacaine. So tiny, tiny volume. But at the same time, you'll be confused. You look at supraclavicular block, huge, huge volume. Look at infraclavicular block, no difference. You still need a big volume. So why? Why are some blocks you only require small volume and some big volume? I think it is really up to what you are trying to block. With the infraclavicular and supraclavicular technique, you are blocking the trunks and the cords, which is a group of nerves, as opposed to a single nerve or nerve root. So I think that makes a difference. Also, it makes a difference what type of local anesthetic you're going to use, whether you're going to use the block for analgesia versus anesthesia. Obviously, for anesthesia, surgical anesthesia, you need a more complete block. When you also look at the time to success, look at the end point of success. If it is only analgesia, you need less. Also, how long it takes to set up the block. So if you always have plenty of time to wait for the block, then yes, you can use a smaller volume to achieve block success. But if it is you don't have a time, you need it to onset is within 10 minutes, then you most likely are going to use the big volume. So to me is, are we looking at just doing this for academic exercise or really apply in our clinical practice? So you and I have to decide on that. If I'm going to use small volume, what am I trying to achieve? I think what I'm going to achieve in this case is maybe for interscaling block, because we worry so much about diaphragmatic paresis. Yes, with small volume like 5 mL, it can decrease the incidence of diaphragmatic paresis. That is correct. When this study targets the C7 nerve root, again, it shows that, yes, you can decrease the incidence of diaphragmatic paresis. So in one study, they're targeting the C5, C6 nerve root. The other studies targeting the C7 nerve root. But you look at this study, by Dr. Sinha's group, decreased to 10 mL. Why doesn't it reduce the incidence of paresis? I think that is what we need to look at, is why. I think also we need to look at is where is the phrenic nerve. If we are doing the block at the level of the cricoid cartilage level, when the phrenic nerve is very close to the brachial plexus, injection of local anesthetic here is more likely to block the phrenic, as opposed to lower down when the phrenic nerve travels now medially between the sternocleidomastoid and anterior scalene. So hopefully that will be less likely to be blocked. I cannot see the phrenic nerve all the time, but this is a nice article looking at the anatomy, looking at where the transverse cervical artery is. Usually the phrenic nerve is just right next to it. So something that you can use as a landmark to trace it. I must say I cannot always see the phrenic nerve. It's usually a tiny hypoechoic structure between the two muscles, sternocleidomastoid and anterior scalene muscle. As you scan from head to toe, you will see that is going medially. So when you have time, try to look at that. The other question is, if we reduce the dose of local anesthetic, can we spare the motor block? I think this is important in the lower limb, particularly when patients have total knee or total hip replacement. You're going to use a femoral or lumbar plexus block. Yes, the incidence of fall is somewhat increased because you are likely to block the quadricep muscle. And Dr. Ilfeld's study has looked at this study using even 0.1% ropivacaine. only 4 milligram per hour, a tiny, tiny dose. In volunteers, after 6 hours, tremendous drop in the quadriceps strength. That tells you that it's very hard to prevent quadriceps weakness with the dose of local anesthetic we use. This study compared 0.1%, 0.2, and 0.3% ropivacaine, and they find that 0.1% is ineffective. So even with 4 milligram per hour, probably is ineffective analgesia, yet there will be a quadriceps weakness. What I think is important is if we are going to continue with femoral nerve block, accept it. You may need to protect the knee properly now, and also have clear nursing protocol. Make sure the patient, when they get up, they have some assistance. Make sure the patient know that there is an increased incidence of fall, and be careful. That is why we are shifting to adductor canal block, because we are targeting only the saphenous nerve, which is better than placebo, but probably not as powerful as femoral nerve block, but it would not cause quadriceps weakness. What are the other benefits? I think you can use a smaller volume now. So maybe prevention of local anesthetic systemic toxicity, particularly in pediatric population. There is also some evidence that local anesthetic can induce nerve injury. This is a animal model. It shows edema and also some degeneration. Whether it happens in human, we don't know. Hopefully it doesn't, because we are still walking. Most of our patients are still walking after peripheral nerve block. I think the other subpopulation is the diabetic patients. They may already have subclinical evidence of diabetic neuropathy. Whether we should now use a smaller volume of local anesthetic to prevent additional neurotoxic injury. Whether that is true or not, we don't know. What we do know is in human diabetic patients, the duration of the block with the same dose of ropivacaine usually lasts longer. Whether this is a clinical suggestion of neurotoxicity, we don't know, or simply because the local anesthetic is absorbed more slowly. So those are the things that we need to work out in the future. What are the disadvantages of using low volume injection? If you do that, the needle has to be very close to the nerve to get a perineural injection. So in that case, there is a chance of intraneural injection. And studies have shown, at least in cadaver, even a small volume injection, you will see that the nerve grows in size, and also the echogenicity will change, usually more hypoechoic. So again, ultrasound-guided interscaling block can still result in nerve injury if we injected it intraneurally. This is why some studies, including ours, are looking at so-called periplexus injection. We don't want to get the needle too close to the nerve root. We want to go just close enough as we inject. We want to see spread of the local anesthetic in the interscaling groove. We accept that. We don't want to get the needle around the nerve and move it many times for safety reasons. Whether it is true or not, we don't know. We are studying that in terms of safety. The other disadvantages are it will shorten duration of analgesia. As you reduce the dose, there's likely that the duration is shorter, and also the block may be more likely to be incomplete. So those are the disadvantages. So if you ask me, am I dropping my local anesthetic volume for most of my peripheral nerve block at this time? I say no. I still use almost the same dose. But if you are worried about the diaphragm, suggest you try lower dose in the interscaling block, perhaps in the pediatric population or the diabetic patients. What are the other things that we are looking at? I think there are many, many techniques out there for TAP blocks, thoracic paravertebral block, neuraxial block. What is the optimal technique? We still don't know, and we need to work on it. TAP block is becoming popular because it's a relatively simple block. These are small nerves. These are the lower thoracic lumbar nerves between the muscle plane. Remember, this block is only good for somatic pain relief. It's not for visceral pain relief. With the original description is this triangle of Bertille bordered by the external oblique, latissimus dorsi, and the iliac crest, and they are trying to block the nerves, again in the thoracoabdominal nerves. And this is how they do it. They simply have put the needle in the mid-axillary line, feel for the 2 pops. The first pop is through the external oblique muscle. The second pop, they think, is through the internal oblique muscle, and the local anesthetic is deposited between the internal oblique and the transverse abdominis muscle. Initial data with the landmark approach show very promising results. Look at the graph here for the TAP block, much lower pain score and also much lower opioid consumption. But for some reason, with the TAP block using ultrasound, we are not able to reproduce the data. And with ultrasound, we can clearly see the 3 layers of muscles, abdominal muscles, and clearly we can see the needle as we inject local anesthetic. We see the expansion in this plane. So ideally, this should be an easy block to do with ultrasound. But particularly when we look at cesarean section, in the context, when it's of analgesic regimen, including intrathecal morphine and oral analgesia, it's hard to demonstrate additional benefit. So the question is why? Is it truly no benefit, or simply we don't know how to do it? So I think that is why we need to study more to figure out what to do. I think this is clearly a block for bigger volume. They look at 0.3 mils per kilo versus 0.6, inject in the same place. They find a wider extent, bigger extent of spread. Also, the place to inject matters. If it is too anterior, it's not so good. If you inject in the triangle or petite in the mid to posterior axillary line, is better because in this case, the local anesthetic is more likely to spread posteriorly, even to the paravertebral space, and have a wider spread. To me, this study makes a lot of sense. It would be a high volume block, and also it is a multi-injection block in order to get the spreading of local anesthetic. So this study looked at 2 injections on one side, 2 injections on the other side to get the spread more evenly. So what I believe we made the mistake when we put the probe to anterior is the spread is more transverse, horizontal. But what we really want to do is we want the spread to be Keflan and Kodak, and that probably would not be achieved by an injection like this. So I've changed my practice. Now if it is a midline incision, a wide incision, I'm doing bilateral block, but I would put my probe this way and I inject it and put a wall of local anesthetic up and down like that. So there is still a lot we need to learn, and there is still something we need to study in the future, see what is the optimal approach, and also if we are going to put in catheters, how to do it. The next is the thoracic paravertebral block. It's very good. Breast surgery, thoracic surgery, abdominal surgery, less likely to see the side effects due to epidural. Also, there is such a hype in the regional anesthesia community because this retrospective review shows that the cancer recurrence rate after thoracic epidural is less. The recurrence rate is less than those receive general anesthesia and also intravenous opioid. So this is something, again, worthwhile to study, and there are many, many centers now looking at that. When we do the block, again, there are many techniques. Is there one better technique than others? If the probe is parasagittal, what we want looking at is the costal transverse ligament. We know that the needle need to puncture the costal transverse ligament before we deposit the local anesthetic into the paravertebral space. If you are going to do the transverse scan, you will see the transverse process and you see the pleura dipping deep here. And the landmark for the needle penetration is different because in this case, you are trying to go through the internal intercostal membrane. As we inject, we want to see the pleura depressed, so that is a sign. So out there are so many techniques out there. We still don't know which is better than one is better than the other. This is a transverse approach. The needle is going in plane. And again, they want to see that the needle is coming here and depression of the pleura as you inject local anesthetic. The concern with this technique is if you put the needle too far in, it may go into the foramen. Remember, bone is the enemy of the ultrasound. When the needle is inside the bone shadow, you don't see the needle. So that is the concern. And also local anesthetic injection here may spread to the epidural space. That's the concern. Another technique, same transverse, but now is outer plane, not that different. Third technique is now they don't look at the transverse processes, they look at in between the transverse processes in the inferior articular process of the facet, and they put the needle right there. So this again, some people do that. And finally, the fourth approach is the parasagittal scan. With this scan, you have used a lower frequency probe, see more than one level, and as you inject, you want to see the spreading of local anesthetic not at one paravertebral level, but more. So the question is which one is safer, which one is better, which one is likely to cause the epidural spread. We still need to work out. I'm not going to spend much time on spine imaging. You have already seen a nice demonstration of spine imaging, but I believe that this is a very useful skill, not for the normal size individual, but patients who may be very big, patients who may have scoliosis or previous laminectomy. This, I think, will be a very useful tool to use. So that, again, I believe is a basic skill for us. The next question is, what is the optimal local anesthetic spread pattern? Right. We have observed different spread pattern. The perineural injection, perivascular injection, intermuscular plane injection, and some that we don't want to see, the intraneural, intravascular, or intramuscular injections. So do we really need an perineural injection every time? For inferior trunk,